Okay, it's showing that it's live streaming on YouTube now.
So
Perfect.
Tonya, let me tell Tonya to join.
Okay.
Okay, it's showing that it's live streaming on YouTube now.
Okay.
So Tonya, let me tell Tonya to join.
What about
Okay, put me
Ready?
on. Yeah.
Sorry,
Hello.
I was trying to sort out my madam.
God bless your heart. Yeah, so we're streaming on both YouTube and just no Facebook. Oh. Are you sure? Fumi said she did Facebook.
You're live
Oh,
now.
yeah. Do we start? We just give it some more minute, a few more minutes.
Sure. Is my internet okay?
Yeah, it is. Okay. It is not the link. That is not the link. Oh,
Are you recording it?
oops. Good evening, everyone.
Evening.
Good evening. This is Dr. K, and today I've got with me Tonya Oburu. It's World Diabetes Day, so we thought it will be helpful if we actually discussed the understanding and management of diabetes. I'm going to start by introducing my guest. So Tonya, welcome. Thank you for accepting the invite. And today we'll be talking about understanding diabetes and also the management of it. I'm sure a lot of our guests will have questions. If you have questions, you can feel free to put it in the chat. I will pick it up from there. So Tonya, who is Tonya? Tonya, actually, her name is Boma Tonya Oburu, but she's mostly called Tonya. And she's a registered UK independent prescriber, clinical pharmacist with a special interest in diabetes and hypertension management. She's also the founder of Diabetes Consults. Tonya graduated from the University of East Anglia, United Kingdom, and she's also a member of the General Pharmaceutical Society of Great Britain. Tonya has a wealth of experience working in hospital settings, both within the NHS, in the United Kingdom, and the private sector. She has chaired also and spoken on the Diabetes UK platform. And she has hosted a variety of diabetes and health related events on her social media platform. Tonya currently works within primary care setting in the United Kingdom with other healthcare professionals such as the endocrinologist, the diabetologist, the nephrologist, the podiatrist, diabetic specialist nurses, cardiologist. So it just tells you that she works with a multidisciplinary team, and that is the way forward with medicine and long-term conditions at the moment. Her aim is to improve the delivery of efficient and impactful diabetes care services to local community in Kent, United Kingdom. Tonya is also an active member of a variety of associations such as Diabetes UK, Clinical Pharmacy Association UK, Primary Care Diabetes Society, to name a few. Tonya is happily married with one daughter. She adores her family, both immediate and extended. And at home, her friends and family refer to her as Tonylicious because she has an infectious personality and smile. You'll find that out soon and confirm that. You can't have music and see Tonya sitting still, except she's not ready to display herself. Lord. She's a lover of God and she's actively involved in church life. She has a community spirit and embraces diversity, so has many friends from all walks of life. So today we're just going to get into it, and we're hoping we can shed some more light on diabetes, which is a long-term condition. There's a lot of concerns when people are informed of the diagnosis. Most of my patients go into panic. So I'm going to introduce myself now. My name is Dr. K. I'm the founder of Healing God Zone. I'm a GP and I practice in the United Kingdom within Bedfordshire. Today, we're going to talk about all things diabetes. And if you have any questions, you can pop it in the chat and we'll pick it up from there. Or you can raise your hands if you want to ask your question. So Tonya, I know you have special interest in diabetes and hypertension. Why have you chosen diabetes and not another topic such as asthma?
That's a good question. Can you hear me? Because I think my internet's breaking. Can you hear me?
Yes, we can hear you.
Okay, good.
Thank you.
Good evening. Thank you for having me on this platform. It's an honor. Diabetes holds a special place in my heart. I lost my mom a couple of years ago, I think about 3 years ago now, to diabetes from a lack of care in terms of a lack of suboptimal glucose control. She was fine 1 minute and someone, mismanaged it and she was dead in 24 hours. And that I've always been involved in diabetes, but then that made me go a step further by wanting to know about the ailment more and more, work with the range of people that work in the diabetes world and influence or help people to live well with diabetes. Because it's not just having it, because a lot of people fear having it. It's not okay to have it, but when you do have it, you can live well, and that's why I chose to go in there.
Oh, that's it. It's good to hear that. I think when you approach something from a personal story, it makes a lot of difference, and that explains why you're so passionate about communicating and managing patients with diabetes. One of the things I'd like to say is that even though Tonya is a pharmacist, she has a major role to play in the management of diabetes. In the United Kingdom, we work in a multidisciplinary team, and the emphasis these days is on seeing the right person for the right condition. So gone are the days when it's just the GP. At the moment, what happens is you see the right person, and sometimes the GP is not the best person for you to see at a particular time in your journey of managing diabetes. So the GP has their role, but also is the endocrinologist, is the consultant, is the pharmacist, is the nurse, and all the allied professionals. So I'm glad pharmacist who actually has special interest in diabetes, and she has accepted the invitation to talk on this special day, which is World Diabetes Day. So, Tony, I'm going to ask you, what is diabetes?
I'm going to try and not be a clinician today and keep things simple. In simple terms, diabetes is referred to as a chronic, so long-term. Chronic being is in your life for a long times, long-lasting, and it's actually a chronic disease that affects how the body turns the food that you eat into energy. So, for example, whatever you eat, the body breaks it down and converts it into glucose, which we all know as sugar. So with diabetes, there is a raised level of glucose level or sugar level within your bloodstream. And the pancreas, which is part of our body, is responsible for producing insulin. With diabetes, you have varying types of diabetes. I'm not going to go into that. That either completely affect how the pancreas produces insulin or reduces the amount of insulin produced by the pancreas. So therefore, the insulin is not sufficient enough to take that excess glucose in the body to where it's supposed to go. I'm trying to be as simple as I can. So diabetes is really a chronic disease that actually causes an elevated amount of glucose sugar within the bloodstream.
Great. That was quite a simple explanation, and I'm sure a lot of people can understand that, avoiding the medical jargon. So, are there different types of diabetes? I quite often hear people say, I'm type 1 diabetes, I'm type 2 diabetes, I'm insulin dependent. What various categories of diabetes or types of diabetes are there?
For the sake of today, I'm going to list them, but we're not going to go into all of it. There are so many types of diabetes. There is type 1 diabetes. Like I said, in type 1 diabetes, their pancreas completely packs up. There is no insulin production, and therefore they are 100% dependent on insulin. There is type 2 diabetes, which there are factors that lead to type 2 diabetes that again lead to the reduction in the insulin production by the pancreas. There is what we call LADA, which is latent autoimmune disease of adulthood. Sometimes most people present as a type 2 and their blood sugars remain quite high for a long time. They have certain features that when they present to you and you notice that whatever tablets you've thrown at them, their blood sugars are not coming down and they have these features, there are further blood tests that we have to do to identify if they're actually a type. Some people call them a type 1.5 because later on there is a complete depletion of their insulin. And they end up being completely dependent on insulin. So they have antibodies that actually fight against them, like type 1. There is also people they've had like their pancreas, like chronic pancreas problems with their pancreas, and then they end up having diabetes. There is steroid-induced diabetes. There's so many types of diabetes. I've just mentioned the ones that I can mention at the onset.
Yeah, thank you. So, in summary, most of the time, people are either type 1 or type 2, and the type 1 will be equivalent to the insulin dependent diabetes, and the type 2, most of the time, are on oral medication, but if they're not well controlled, could go on to insulin. And the type 2 is usually the adult onset diabetes. Or very often I hear patients ask, what does it mean to be pre-diabetic? So there is a group that is called pre-diabetes. Do you have anything to say? What does that mean?
So pre-diabetes is a condition, obviously, that we have levels in which we measure it, and I'm not going to go into the levels. But once you're classed as pre-diabetes, it's a precursor to diabetes. It means that there is beginning to be a rise in the blood sugar in your level. It's not high enough for you to be considered as a diabetic, but it's high enough for it to cause a trigger that you can actually go into type 2 diabetes. So when you're pre-diabetic, for some people, depending on where in the scale that they are, some people are closer to being diabetic, but they still, because they haven't had that blood test, to
You're frozen. Tonya seems to be frozen at the moment. Her internet seems to have some issues. I'm sure she'll come back on in a minute. So while we're waiting for her, she was actually talking about pre-diabetes. And pre-diabetes, like she said, is a precursor to having diabetes. So when you have your blood test done, if it's at a certain level or within a certain range, your healthcare professional or your GP would in the UK would refer you to a program where you actually will be taught how to manage. Tonya, are you back? We've lost your volume. Yeah, okay, great stuff. Hello, are you back? I think Tonya might be having some internet issues. She'll join us in a minute. Yeah. So with if you found to be told to be pre-diabetic, what you need to do actually is to slow down and pay attention to your lifestyle and your diet, so that you do not advance to become diabetic. If you manage it very well, most people would then go back to being normal. But if it's not well managed, then you might go on to full blown diabetes. And like I was saying, in the UK, there is an educational program that you can be referred to, and there you learn all the different things you need to know to help you prevent progressing on to being a full blown diabetic. Tonya.
Yes.
Okay, sorry, I think your internet for a minute went off. Yeah, so yeah, thanks for that. So I think I was going to ask you. So we've talked about the two main types of diabetes. Is one more serious than the other?
We would say that they have equal, or personally, I think because of the complications that can arise from a mismanagement of the disease, yes, definitely, they can equally lead to complications. However, I'm not saying that one is more serious, but however, because people who live with type 1 diabetes are completely reliant on insulin, that can in some cases be considered as quite serious, because whereas a type 2 can eat a meal, go about their activities, and their blood sugars can rise without causing any immediate noticeable harm, people with type 1 diabetes can actually have very elevated blood sugar levels that can actually lead to problems. So looking at both of them, yes, they do have equal complications if not managed well. But type 1s, if they're not reliant, well, because they're reliant on insulin, it can actually cause some problems for them if they don't have their insulin straight away.
Okay, so it sounds like people on type 1 diabetes seem to need to pay more attention and more stringent, be more strict with the instructions that their diabetes specialists give to them compared
Yes.
to type 2. And I think with type 1, most of the time, the onset is while they're younger. So most of them actually struggle more because it's almost like, how do I cope with this? But if you join a diabetic program and you listen to your healthcare professional, most of the time you can live a healthy lifestyle. So I was also going to ask you, so can diabetes be cured or reversed?
So like I said, with type 1 diabetes, the pancreas is completely packed up. There is nothing they can do about it. It cannot be cured, although there's research going into it. So I'm sure one day there will be something that would be able to help them. So with those, they're completely dependent on insulin. With type 2 diabetes, like I said, there's some that are, it's very tricky to know whether they're type 2 definitely, but the usual type 2 diabetes can be reversed. With lifestyle, with diet, we can reverse that. But you have to have great works, the things that you have to do to be able to work with your clinician to be able to reverse the diabetes.
Thank you. Are there certain races that are prone to diabetes, or is it just same across board, irrespective of what ethnicity you are?
There are races, so I think it's because of certain socioeconomical factors, the dietary factors, there's still research about genetic factors that contribute to it. But certain races like your Black Africans or Afro-Caribbeans, the certain Asian communities, some Hispanic communities are more prone to diabetes. And there's discussion about whether our diet and lifestyle contribute to that, are heavily contributory factors to causing us to be more prevalent to having type 2 diabetes.
Great, because we find that with the Afro-Caribbean diet, for example, it's very, very high in starch. And not only is it high in starch, we love our large quantities. So a lot of the Afro-Caribbeans struggle with the diagnosis of diabetes. And I think that's the greatest challenge as to how do I reduce my portions? How do I live a life with the diagnosis of diabetes? Because most of the food that the Africans, I can talk for ourselves, is actually very starchy, high in carbohydrates. So yes, are there certain foods that increase our risk of diabetes?
So, like I said, the normal foods that we eat get broken down to release into glucose, which is sugar. But there are certain foods that increase those sugar levels a lot more, and those are your carbohydrates. And you have things like your white rice, your pasta, being like spaghetti, you have your potatoes, your yams, for those of us in the Afro-Caribbean community, plantain. They actually, when ingested, so we're not saying cut it out, we're saying cut it down, because when they get into the bloodstream, they do get converted into glucose. Funny enough, you talked about portion sizes. I did this session earlier today, and I'm not sure if you can see it. I normally have a plate size that I show to people, and this is like a normal plate size. And we normally say that half of the plate, 50%, ideally, should be vegetables, and the other 50% should be split between your protein and your carbohydrate. And in clinic, I normally say to people, start with your vegetables, go on to your protein, and then go on to your carbohydrate, because that way you get fuller. So by the time you get to your carbohydrate, you're not eating as much as you should, because that would then encourage. Whereas in an African setting, I'm African, when you dish the plate, the whole rice sits on the plate, and then you have the chicken on one side or in a separate plate. Some people fill the rice and then they serve you chicken and vegetables on a separate plate. We normally encourage people, you can still enjoy your food, but just be wary about the quantity that you eat. And then going on to that, even within the carbohydrate, we normally look at like your glycemic index. So things are like your whole meal. So rather than going for white rice, we normally encourage go for brown rice, go for brown pasta, go for sweet potato against normal potato, because they break down a lot more slowly when they're in the bloodstream, and they keep you feeling fuller for longer. And that way you don't have that grazing effect to want to always go back to eat food.
Great. If you have any questions, you're free to raise your hands. We're happy to stop and take questions as we go along. So you've informed us a lot about how the different ways that people can pay attention to the diet when they get that diagnosis, or even pre-diabetic. So then my next question will be, what are the other vital things that need to be done to live well with diabetes?
There are a couple of things that we encourage. So apart from diet, which we've talked about diet, we talked about portion control, we normally encourage exercise. And I was just having a dialogue with someone earlier today saying, as Africans, and again, being African, forgive me, we tend to be very comfortable in our homes and we don't want to move. And some of us have to encourage ourselves a lot more. You and I, Dr. K, we sit at a table, at our benches, yes, or tables rather. We press a button and the patient comes in. Or you might walk a couple of steps. Sometimes my watch tells me I've only done 1,000 steps in a whole day, because you're trying to move as best as you can, but you have an office job. So we try and encourage activity. So when we say activity, we normally encourage at least 30, 150 minutes a week, which is about 30 minutes a day. It can be quite difficult. Some people say 30 minutes, that's a lot. I'm a mom, I'm this and that. But we normally say as best as possible, because diabetes is your life. Especially if you're living with it, or if you have pre-diabetes, you don't want to go into the full-blown or have the complications from diabetes. So some people break it down. We normally say, instead of trying to do 30 minutes, you can do 15 minutes in the morning, 15 minutes in the evening, or you can just do 30 minutes as a full burst. But trying to aim for 150 minutes per week, giving yourself interval, looking at your portion control, and working with your clinicians to be able to look at your levels. So don't just say I have type 2 and if I do diet and lifestyle only, it will reverse my diabetes. Your levels might be very, very high that you actually need medication. I'm not saying we keep you on those medications. Most times people are on those medications for life. But most of the times we say work with your clinician, get on the medications if you need the medication. And then afterwards, we can actually, as your levels come down, we can review the medications and reduce them accordingly based on what your blood sugars are doing.
Great, great. The other things, obviously, what we advise generally for every other person would be things like make sure you stay hydrated. Also, your healthcare professional will talk to you about the need for regular eye checks, because diabetics do have challenges with their eyes. If their sugar level is not well controlled. So you have to have your annual eye check and just your regular blood test, because the blood test just is monitored. So like Tonya said, we can see where your levels are and if your medication needs to be controlled. The other thing which we do recommend is that you pay attention to your skin and especially your feet. Because you cannot afford to get an open wound. If you get an open wound as a diabetic, it takes a bit longer to heal. So, and then some diabetics, when they're not well controlled, will have nerve problems. So you just find you might have pins and needles, you might have a bit of loss and sensation in your feet. But if you have your regular feet check and you see the podiatrist from time to time, you can stay on top of that. So thanks for that. The other question I was going to ask you is, so we've talked about, I want us to talk about the complications of diabetes actually. So what are the complications that could occur if you have diabetes and it's not well controlled? Because if you have well controlled diabetes, it's likely that you can live a good life. But if it's not well controlled, there's some complications that we want to try and avoid.
Right. That's a good question, because a lot of people fear the complications. But the thing is, like you rightly said, if you work well and your control is actually good, then obviously we can reduce those complications. But we kind of divide the complications into major and minor, not that anyone is less insignificant to it, or rather not as significant as the other. But the one that we worry about, we worry about all of them, but the complications just like your chronic conditions around the heart. So it can lead to strokes, it can lead to heart failure. And that's why when we manage your diabetes, and I have to throw this in, we don't just look at your sugar level, because people go, you just do diabetes, you just look at sugar. We don't look at sugar alone. We have to look at what your blood pressure is doing. And you have to have a particular blood pressure we target, a particular blood pressure target. We look at what your cholesterol is doing. We look at whether you smoke, because all these things increase your risk. So we talked about the heart, like it can lead to stroke, it can lead to a heart attack. You've already mentioned, Dr. K, that you have the complications with the eye, where you have what we call diabetic retinopathy, which has got to do with the retina, and the blood vessels in the retina. You've got that. You've got your foot. You've mentioned that as well, where it can lead to neuropathy. So the neurons, or the nerve endings around the foot, people can start to lose their sensation. So if they get those wounds, then they're slow to heal, and they can therefore lead to ulcers, which may lead to amputations. In men, it can lead to things like erectile dysfunction, which can cause problems in marriages. So they're different. There's also problems with the kidneys. It can lead to chronic kidney disease. There's so many complications, and it's not about actually scaring people, but it's actually making sure there's gum disease. We always forget the periodontal issues that diabetes can cause. So we can lead to gum disease and other mouth-related conditions. So these are the most of the ones that like we talk about to try and prevent. Because I always say that diabetes is like a spider web. It leads into different things, and there's so many other factors that need to be considered for it.
Thank you for that. I'm sure a lot of people will have found that very helpful. So I have found with my patients, when they have received the diagnosis of diabetes, a lot of them actually get very anxious, and a few actually do get depressed. And some are actually in denial. So there is a mental burden associated with diabetes. How do people deal with this, with the mental burden associated with diabetes? What's the best way to deal with it? How would you advise people with diabetes when you get that diagnosis? What advice would you give to people?
Well, normally, in my practice, I try and simplify things for people because it's a lot for you to deal with. Someone's telling you you've got diabetes, and immediately you say diabetes to someone, their brain is going, "Oh my God, I'm going to go blind. I'm going to lose my kidneys. I'm going to die." And I always try and tell them, go back to the basics. If you work with us and we work with you and you do what we need to do, we can obviously keep it under control. But again, like you rightly said, that there's the mental aspect that has to deal with the diabetes, where you have all these things that you're going on, and there is also stigma in certain traditions where you think, I cannot tell my family that I've got diabetes. One, because people will say it's because you're overweight. I've always told you that you should lose weight, and you've not lost the weight, so you've now given yourself diabetes. There's all these things. I always say diabetes is not it's not a journey for you to walk alone. There's so many support groups. There's support groups in England. We have Diabetes UK. There are people their clinicians are there. They can signpost you. There are loads of diabetic groups that people have lived well with diabetes. The diabetes.org.uk for those of us here in the UK, and I think America, I don't know about Nigeria, but there's support groups. Find someone to talk to. And find someone to be able to walk you through the journey and how to better the diabetes. And we're trying to, and I think this awareness is to take away that stigma from our culture. To say the fact that someone is overweight does not mean that they have diabetes. Obviously, it increases their risk, and so on and so forth. So in terms of the emotional burden, is actually looking for the right support groups, speaking to people. Don't keep it on the inside. There's so many support groups that are available to support you through this journey that you're in.
Excellent. And also, I wouldn't fail to mention the fact that if you find yourself struggling with anxiety, depression, low moods, insomnia, any form of mental burden, please get in touch with your GP. There's enough help out there, and it's not always about medication. So sometimes you might actually find that getting some psychological therapy might help. And you have cognitive behavioral therapy that helps you. It teaches you how to manage your thoughts and the stress. And most of the time, if you get that done quickly, or you get help from those services, you find that you might not actually go onto medication. And even if you have to go onto medication for anxiety or depression, you don't have to be on it for life. Sometimes it's just for a period of time while you're trying to settle into the management of diabetes. And once you get better, then in discussion with your healthcare professional, including the pharmacist, you can slowly wean off the antidepressants. So being on antidepressants is not always a bad thing. The important thing is that you seek help if you feel you're struggling from any form of long-term illness, not necessarily just diabetes, any long-term illness. seek for help, and there's help available. And antidepressants don't always have to be for life. You just need to make sure that you work with your healthcare professional to reach that place where you want to be, which is where you can live your normal life without being anxious or depressed or laid up in bed. So yeah, thanks for that. So you've touched a bit on this, but the question is, how do we get rid of the stigma around diabetes?
That's a difficult. That's a question that obviously we're all working with, and I think it's providing education for people, providing the knowledge base, like what you're doing, what I'm doing, trying to understand that yes, somebody can be overweight, yes, somebody can have a family history, and there is nothing. I think it's because people fear those complications. Or my uncle's leg was cut off, or my mother's leg was cut off, so therefore I have diabetes and my leg is going to be cut off. The reason why those things probably got to that level was because there was not adequate information to be able to manage those conditions properly. And I think with the right understanding and with the right information and pointing them to the right people, not Joe Blog on the streets who's just gone to Dr. Google and, to find information and say, oh my God, I saw this leg, without really understanding, because I think the picture in people's head is all the complexities of diabetes that they have seen. But then we need to go back to the basics. Have they been supported? Have they worked with their clinicians? What are their diabetic levels? Have they kept to their diabetic levels to prevent these conditions from actually worsening? So these are the things that we actually look at. And to the best of my knowledge, it's actually continuously sounding it out, providing information, providing knowledge, so that when you actually speak to people, you speak to them because you're empowered with the knowledge to be able to support them through the journey that they're going through.
Excellent, excellent. So we've all heard it. Knowledge well applied is powerful. And there's a saying that says, if you want to save your millions, just hide knowledge in a book, and the Black community would never find it. So I'm sure we've destroyed that myth today, because after this session, I hope you'll actually reach out. If you're diabetic, if you're in the UK, you can get in touch with Diabetes UK, and they've got loads of information. You can also get in touch with Tonya. At the end of this, we'll tell you how you can get in touch with her. She's very passionate about management of diabetes, and she'll be able to give you advice. So one of my last questions will be, many people actually associate the management of diabetes with doctors and nurses. How can a pharmacist help with the management of diabetes? Because I'm sure a lot of people will be out there thinking, she's a pharmacist, what's she talking about diabetes for? But please shed some light on that.
That's my battle till tomorrow. So obviously pharmacists are great, and I'm a pharmacist. I represent the world of pharmacy with all pride and gratitude. We spend time at university learning about conditions, possibly not as much as doctors have, but then when you graduate, there are different aspects of pharmacy that you go into. There's the community pharmacy, people like your Boots and Lloyds, or your high street chemists, as they say. You've got the industry people who make the medications. You've got your hospital pharmacists that work with doctors. And you've got now general practice pharmacists who go into general practice, and they have done extra qualifications. They have gone through the rigmarole. They have learned, and they have been put through the fire to come out to be able to specialize in whatever conditions that they have that specialist. So in terms of pharmacy, I haven't just come out of school of pharmacy. I have been a pharmacist. I'm a prescriber, so I can prescribe literally anything, within my scope of practice, and diabetes falls within my scope of practice. I've spent the time learning, and I'm still learning about diabetes. And like I said in my bio, I work with so many other clinicians that on a day-to-day, we're picking each other's brains. So pharmacists are useful. And we look at the holistic picture like every other person, but we're able to look at the drugs. We're able to see the complexities of what these drugs can cause. We're able to look at so many other factors that some of the healthcare professionals may just focus on one area, but we are able to come with a full capacity, an all-round picture to manage the condition. So in my clinic, I don't just do blood sugars. I look at your blood pressure. If your blood pressure is raised, we manage your blood pressure. I can start you on medications. If your cholesterol is raised, I will put you on a statin if we need to. If you're getting what we call atrial fibrillation, which is another topic, we can start you, or we can do the diagnosis. So we have a lot to bring to the table. And yes, I do get a lot of people. I did initially, but a lot of people now know that there are not many of us out there that are involved in diabetes. But now within my area and the vicinity that I work in, actually patients they call the practice and they don't want to speak to anyone. They want to talk to me because they know they've tested you, they've seen you, and you're doing the work that you're doing. So we add to the team.
Excellent, excellent. And I think the key word in there is that a pharmacist works within a team. So as a GP, I can do diabetes to a certain level. I cannot do the fine details about the medication. I can prescribe it. But when you come to dealing with the complications, the side effects and things like that, I don't have the time to sit down and go into details with you. The pharmacist is there because that's what they study, to actually unpick it. What side effect? Why are you not taking your medication? When do you take it? They have more time to actually look at the broader picture with you, and they work with a team. So in my surgery, my life is made easier by having pharmacists who deal with the medication. So I deal with the illness bit of it, I deal with the disease bit of it, and then I send the patient off to the pharmacist. And a lot of times the pharmacist will send me a message saying, "Oh, Dr. Cook, why don't you think about this?" So yes, it is the fact that every person has their role within the team, and the pharmacists actually play a key role in the management of long-term conditions, alongside nurses, doctors, consultants, podiatrists. So I think one of the message we're passing is that you will be channeled to see the right person for your condition. So at a point in time when you get the diagnosis, you may have to see the nurse who breaks it down, and then you go over to the doctor who then prescribes, and then you go to the pharmacy who follows you up or even explains the side effects of the medication to you. If you ask me as a GP what's the side effect, I tell you to read the leaflets. I might tell you the common ones, but I can't tell you everything because that's a bit deep. So yes, so I'm glad we're having more allied professionals coming alongside GPs to manage long-term conditions. So Tonya, we've spent quite a while talking about the different aspects of diabetes, and I really appreciate your time and your contribution today. You have shared a wealth of knowledge about diabetes with us, and as we said at the beginning, this is actually to raise awareness. It's to debunk some of the myths about diabetes, to take away the fear. Some people, once they're told they have diabetes, think, "Oh, I'm dead meat, that's it. I can't eat what I want to eat. I can't live my life again." But no, you can still live a good life if you have that diagnosis of diabetes. The important thing is to do the right things and to work with your healthcare professional. So Tonya, I'm going to ask, if people have questions, they want to get in touch with you, how do people get in touch with you? Tell us a bit about yourself and how people can get in touch with you.
Well, on social media, I'm Diabetes Consults. We operate not under my name. If you go to my name, it's just my personal stuff. But the social media platform is Diabetes Consults. You can follow us on there and you can actually send us a message. We do our best. If it's a clinical complaint, obviously, or a clinical problem, we will direct you to where you need to go. If you also have, if you're not on social media platforms, you can send us an email, which is info@diabetesconsults.com. And we do our best to respond to you on there.
Excellent. So there are a few questions which I'm just going to, I don't know if you've seen it in the chat. So it says, what has genetics got to do with diabetes?
Okay, so there are obviously genetic factors, and like I said at the start of the conversation, that type 2, they're still undergoing most of the genetic factors, but mainly around type 1. We always say that most likely if someone presents to you with certain symptoms and they say to you that their mum or dad or grandfather, first degree relative, has got type 1 diabetes, then that predisposes you, because there's something within your genetic factors that can actually predispose you to have that that type 1 diabetes. However, in type 2 diabetes, the fact that you have a first degree relative that has had type 2 diabetes increases your risk factor to get type 2 diabetes. Whereas type 1 diabetes, because there is an antibody, an antibody that fights against the production of insulin within the pancreas, that antibody is likely to be replicated in the genes if you end up having type 1, or maybe your child, it skips a generation. However, in type 2 diabetes, it increases your risk factor of having type 2 diabetes.
Thank you. So you quite often hear when you will be asked the question, is there a family history of diabetes? And that's because it is a risk factor for developing diabetes. So if there's diabetes in the family, you want to pay attention to your diet, your lifestyle, and all the useful advice we've given here today, so that you do not go on to develop diabetes. So I hope that answers that question. Genetics does have a role to play. And if you have a family history of diabetes, then you need to pay attention, because you could be at risk of developing diabetes. That's all the questions we have for now. I don't know if anyone else has a question. If you have a question, you can either put it in the chat, or you can signify by raising your hands, and we'll be happy to take it. So I cannot see. I'm trying to see if there's anyone. Could you be diabetic and not know?
Yes. So most of the time we say, like when we sit in conferences, that some people, it can take up to 10 years for the symptoms to start displaying, for them to display the symptoms. And most of the symptoms, which we didn't really cover, were like increased thirst, frequent urination, either repetitive thrush, being extremely tired. Those are the symptoms, some of the symptoms that you have. Now, there are people that walk around without actually knowing, and that's why we always say that if there is a risk factor, if you're overweight, if you have certain origins, if there's a family history of diabetes, rather than waiting to get those symptoms, to get yourself checked at least twice a year, or at least once a year, we normally say. If not once a year, then once every 2 years. Have a blood test, where we actually check your how much sugar is within your red blood cell, and then we can know whether you are within the normal range, you're within the pre-diabetic range, or whether you are in type 2 diabetes. We have had people who walk into my clinic and their levels are 3 times above the normal level, and they have no symptoms. It is just an experimental finding. Somebody just said, oh, let's just do this. So yes, you can obviously have diabetes and not know that you do have diabetes. So please get yourself checked with all those things that I've said, all those factors that I've said. It doesn't do you any harm to check yourself at least once a year to make sure that you're not in the pre-diabetic or in the diabetic stage.
Thank you. The other thing which I'd like to add to that is, if you find yourself getting recurrent infections, or maybe you're getting recurrent boils, it might be worth you asking your GP to check your blood sugar level, just to make sure you're not diabetic. Also, if you're between the age of 40 and 74, did you know in the UK you are actually entitled to a free health check, NHS health check? And what that health check does is actually looks out for people that would have things like hypertension, diabetes, high cholesterol without knowing. And all these are actually risk factors for diabetes. So please, if you're between age 40 and 74 in the UK, United Kingdom, and you haven't had a health check done, NHS health check, in the last 5 years, go along to your GP and ask if you can have one done. They'll check your blood sugar level, make sure you're not diabetic. They'll check your blood pressure and also your cholesterol level, because it's very important that you do not have very high cholesterol, as it might clog your arteries and lead on to other long-term conditions. I don't think there's any other question. Message. So I'm just going to quickly go into the chat box to see if there's any other question. Okay, so Olayinka asks, if you're on medication for blood sugar, but the blood sugar becomes normalized, say between 4 to 8, do you need to continue on the medication? That's a good question.
I would say that don't stop the medication, have a review with your clinician, because when you're checking your blood sugars, what you actually get is actually a feature of what's going on your, according to what you eat. In England, we use HbA1c, or in certain cases, we would also use your random blood sugar levels or fasting blood sugar levels. If your levels are coming down, depending on what medication that you are on, we can either say, no, remain on that, and let's actually check you back again in 3 months or 6 months, or we will trial reducing the medication. But if your medication is reduced, I always say we need to have a repeat blood test after 3 months, because anything can happen. Your blood sugars can go back up and you're thinking, oh, my medication is reduced. Most of the time, we will keep you on it if we actually reduce it, because we look at it. If it's too low, or it's taking you back down to where you're no longer pre-diabetic and you're in the normal range, we can trial reducing it from either a very high dose to a low dose, and then saying have another blood sugar within have another HbA1c test within 3 to 6 months. I can see, Olayinka, you're saying that your HbA1c is 45 in the last 6 months. That is, it depends on what medication that you're on. Again, I don't have your clinical details in front of me, but it's a conversation that you should have with your clinicians. But if you decide to come off or reduce the medications, then you would need to repeat your blood test in 3 months after stopping the medication to see whether your blood sugars rise. And if they do rise, you might need to go back up. If they don't rise, then obviously you stay on the reduced dose, and then just keep having regular checks.
Thank you. The other thing I was going to add to say to Olayinka is, if your blood sugar is actually between 4, because you're talking about your BM, I believe. So if your blood sugar is between 4 to 6, for diabetics, the recommendation is it stays between 4 to 8. So that simply means your medication is working and you should continue on it. And just like Tonya said, please do not stop your medication without discussion with your healthcare professional. If you stop it, it takes longer to control it, to take it back to where it was, and also then you could stand the risk of complications. What you need to know is if your blood sugar is consistently below 4, then that is when one might begin to think of reducing it or actually stopping it. But between 4 to 6 just means the medication is working. And the key, like Tonya said, is to have those regular blood tests to monitor the effect of medication on the control of the diabetes. There was another question which was asked.
I can see on here, it says if you have a family history of diabetes and you don't have any symptoms and blood test results are normal, are there lifestyle habits to be mindful of? Mercy, thank you for that question. The answer is yes. You know, like if you have a family history, you've had your blood test, they're within the normal range. All the things that we've discussed earlier about lifestyle, we would encourage you to continue with those lifestyle. So obviously keeping as active as you can possibly can, encourage 115 minutes of exercise a week if possible, looking at your diet, making sure that you're reducing those foods that are likely to convert your carbohydrate to glucose, which is sugar in the blood, just reducing the amount. And again, have regular blood tests, because if you have a family history, like we've discussed earlier, there is a risk factor for you to get diabetes. So it's ideal that you at least check your blood sugars at least once a year, just to make sure that you're still under the category that or within the category that you're supposed to be. But lifestyle, and diet can never really be re-emphasized.
Excellent. Thank you so much. I have learned so much today, and I hope everyone else has learned a lot. I don't think there are any other questions in the chat box. So at this stage, I'd like to say a big thank you to Tonya. Oh, one moment. There's another message. Let's see. The questions are coming in now. Okay, that's it. Thank you so much. So thank you, Mercy. And thank you to everyone who's joined us today. I hope you've learned something. And you can access this on YouTube. And also, if you have any questions, like I said, you can either DM me at Healing G Zone or Tonya at Diabetic Consults. I hope you have a lovely evening. And once again, thank you, Tonya, for being my guest.
Thank you for having me. Thank you so much. Good evening, everyone, or good night, rather.
Everyone.
Yeah.